Okay, welcome to Spine Conference. Today's discussion will be sacroiliac fusions, and we have the distinct pleasure of Bobby Brombeck being with us. Woo! So this is a real case, and I don't know what to do, and I was hoping you guys, and I haven't done surgery on this lady yet, so I was hoping you guys would help me in this matter. So she's 61, it's a real case, 61-year-old woman with left hip pain. She's had pain for years. It radiates to her left buttock, left groin, entire left lower extremity, she says, feels numb sometimes. She had a left sacroiliac Rialto fusion, which is the Medtronic percutaneous product, 2016. She said initially she was okay, but then last 2 years she said she's been having pain. She has a history of rheumatoid arthritis and fibromyalgia diagnosed in 2010. Other than that, she's a pretty healthy woman, normal body habitus. Exam, I'll go over in 1 second, but these are just the x-rays. So her pain was exactly, and one more thing I want to just say. Bobby, if I say something wrong, please interrupt me. And if anybody else wants to comment, please interrupt me.
Okay. Say something right, I'll interrupt you.
All right. So this is, where do you see SI joint pain? So this is the distribution that most people have SI joint pain, mostly gluteal, but sometimes lower lumbar, sometime in the lower extremity. So this woman was a classic SI joint pain, but this can be any, well, what else could this be? So can anybody give me any comments? What pain in this distribution, what else could it be? It could be the S1 dermatome, exactly.
What?
Yeah, maybe something else, maybe the L5 nerve root, maybe
Right.
central L4 or 5 stenosis.
Exactly the same as, right.
What else could this be? What's the most common thing with low back pain? Patient sees you in the office, low back pain. You guys are orthopedic surgeons.
Lumbar strain.
This could be an annular tear or something, a disc disease, very common, right? What else can give pain here? What other anatomical structure on the spine? Facet, yeah, facet, exactly. Facet can be exactly like that. So, all right, so how do you test for sacroiliac joint pain? So I have all the tests here. Granted, I don't do them in the office. I usually just do the one Paul Durian taught me. But
Taught you more than once.
all right, I forgot them all. So the compression test of just pushing, going behind the patient, pushing down on the SI joint. The problem is all these things cause pain. Distract the pelvis, that puts stress on the SI joint. Flexion, abduction, external rotation, this is what I usually do.
Most common test that we can usually do.
Yeah, most common is what I do. I don't know how to say this Gainsland's test, but just basically extend the hip joint and stabilize the pelvis first and then extend it. That stresses everything though. Just thrust backwards on the pelvis. And Fortin's finger test, basically, but I do this with every patient. I say, take one finger and point to where the pain is. And so they point right to the SI joint. And that comes from the study where he injected normal people. And then a Gillette test or a Stork test, basically stand on it and see if that causes pain. I assume because all the forces go across it.
When I do that test, I'll have them actually try to hop up and down on that one side to see if it reduces the pain more than just lifting a leg. See if I think that's a little more sensitive, I would think, if they're loading it than if they're just lifting a leg just slowly on one side. So,
okay.
And there's one other test that is physiatrist taught me, and it's called the long sit test. And that's where you have a patient laying flat and you're holding your fingers on their median iliac, and you have them do a sit-up. And if your normal person does a sit-up, the median iliac will move symmetrically. But if there is an asymmetry in the motion of the SI joints, when they do a sit-up, you'll see one side will lengthen more. And then when they lay back, they'll straighten out. So that was a test that a physiatrist had shown me that can show that there's some asymmetry in the movement of the SI joint. It's called the long sit test. If they can do a sit-up, depending on the happiness and stuff. But
how much motion's in a normal SI joint?
Pretty minimal, but there's enough rotation there where you definitely, I think, if you
We're
talk
gonna
to therapy.
we're gonna go over that point. It's a very good point. We're going to that point. So the exam, you need to have many of these to be positive for it to be specific to the SI joint, because anything, person with back pain, all these things are probably painful. So this was studied. You need at least 3 of these to be specific for the SI joint.
If I could add another.
Yeah.
I don't do all those tests or didn't do all those tests, but the tests that I thought were most reliable were the tests where you lock the hip against the pelvis no matter what you were doing, versus the Faber test, to truly load through the pelvis. Whereas hopping up and down or all those compression tests, there's so much involved of going through the hip. But once you lock the hip either in full flexion up like a Thomas test, putting it in extension, or the Faber test where you lock it in abduction and external rotation, that's when I think you're truly loading up the SI joint more than these other things that I think can be confused with a whole bunch of other spine pathology to me.
There's one other test that I also do is lay a person on their stomach, and I actually will push on their sacrum and see if it reproduces the pain of the SI joint. You could actually push on the spinous processes and see if that causes pain, which would load the sets or the segment. But then if you're right on the sacrum and you're pushing on the sacrum and it reproduces that unilateral pain, that's just another test to kind of localize it, as Bobby was saying, isolating the movement in that one area.
Okay, so let's just go over some anatomy. The SI joint has a cartilaginous portion, it's a synovial joint, and then a fibrous portion, which is more like an interosseous membrane joint, like the interosseous membrane of a forearm. And which area is more likely to fuse? I'm just going to ask everyone, the cartilaginous portion or the fibrous portion where there's just ligaments? What do you think, Bobby? Or does it matter where you fuse it?
Well, I think if you get bony fusion across it, you stop the motion. So I don't know that it matters where you fuse it, because I don't know that once a joint truly stops motion, do you have pain with motion with loading with that joint? That's a question.
But probability, if you had a probability, if you could magically say, hey, I'd want my fuse, it's more likely if you...
I try to fuse the cartilaginous portion.
I mean, that's what I think too.
I think all the things, all the work is addressed trying to get that anterior portion of the
and I think it's a lot wider over the fibrous portion.
Much.
So, I mean, less likely. I mean, if you get it diffused, then you're done. You fused it. But I think it's probability wise. Okay, so these are just issues I want to talk about. So, just the anatomy of this sacroiliac joint, the cartilaginous portion, it looks like a C. And just so everybody can see the sacroalar, everyone knows the sacroalar line where the SI joint is, the sacral promontory, which is not close to the SI joint really, where the foramina are, and all the relationships of these are kind of important during the surgery. So this is what I just said, sacroalar line, the posterior area of the spinal canal. That's a lateral view, of course. And there's my artist's depiction of pretty much where the SI joint would be. So that, and I think it varies. So you have to look at, look at the CAT scan, every case, just say, hey, this one's more near the notch, more higher, lower, so you can plan the surgery. And this here's an anatomical specimen. Some people say it's called the auricular part of the joint. This looks like an ear or a C, just above the sciatic notch. And then the fibrous interosseous ligament region is posterior and superior, and that's a large area too. So there's 2 different areas, cartilaginous portion and the fibrous portion of the sacroiliac joint. And most of, I think, the strength comes from the posterior ligaments where they're extremely stout. And also there's very little capsule there posteriorly, so the fluid from the joint exits posteriorly because there's not really a capsule there, and that's why you get sacral nerve root symptoms from an inflamed joint. And this is just the anterior portion where the ligaments aren't as strong. And the sensation from the SI joint comes dorsally from the sacral nerve roots. And this is important. Well, I'll go over that in a second. But here's another depiction of the sacroiliac joint, the fibrous portion and the cartilaginous portion. It's shaped like a C. And so let's go over how much motion there is. I think most of the studies say in terms of millimeters translation, like 1 to 2 millimeters translation, and then they describe the rotation as nutation. I'll tell you what nutation means, but it's usually 2 or 3 degrees. So it's very, very minimal, the amount of motion.
I can tell you this, when I've been operating on pelvises for trauma or for this, I've tried to move the joint to see it. I mean, you go into the foot where things are tight and you expose a foot joint or and you stress it while you're there and you actually are looking at the diarthrodial joint and you're looking for motion. It's very difficult to see. I can't see it in the SI joint. My eyes cannot see it. It's that less. I mean, you don't have, when you're operating the SI joint, it's not an easy thing to see anyway, so you're not looking at it as open as you can. But go to any cadaver and do an exposure either anterior or posteriorly. You get right down and you're looking at the anterior SI joint and try to move it and tell me you see it. It's hard. Doesn't move much.
A couple millimeters. It's hard to see a couple millimeters.
Yeah. One of the studies said 0.6 millimeters. 0.6 of a millimeter of motion.
But it's interesting, there was a study, I'm trying to get this through cobwebs to remember this, I don't know if you're going to mention this, where they actually were looking at pelvic incidence and males and females, flexion extension x-rays, and they actually found that the pelvic incidence changed more so in women than men, if I remember correctly, because they felt that it was due to the movement of the SI joint when you were stressing it, flexion and extension, that there was enough movement of the SI joint that your actual pelvic incidence, we say is a fixed entity, did change.
I mean, I think because it's a diastrodal joint. I think there's motion there because it's a diastrodal joint. I can't imagine nature creating a diastrodal joint that isn't meant to move so. I'm just telling you, I think it's really low. And the original studies were all done with x-rays, standing x-rays, and trying to control the beam and everything else. And once they repeated them with CAT scans, they couldn't measure it. I mean, it's just hard. I'm not saying there's no motion. I'm saying that it's just hard to see it, and it's not that much for the number of people that have this problem.
So I did a study with Brian Cunningham looking specifically at female versus male cadavers and looking at SI joint motion. And female cadavers have almost twice the range of motion as their kind of age-matched male counterparts. We weren't able to control for whether they were pregnant at any point, which is kind of the big thing you want to look at because of the large luminous changes. But in the fused and unfused state for lumbar only non-SI fusion, they had about twice as much range of motion. Just based on thinking.
How old were the cadavers?
Cadavers were all about, it was from 2 to about
Like 70-year-old?
They were 60s to 80s was the range.
I think a young woman probably has motion, and an old woman probably has no motion. Right? So I guess age has a lot to do with it. Well, the people the anatomists who gave a word to the motion of the sacrum, they used the word nutation for the degrees. And I thought to myself, what is that word? So nutation, the earth spins, and then the axis changes. That's called precession. And then the axis, the precession actually changes just a tiny bit in the earth. That's called nutation. So I think the point that these people made is that it's very, very little motion and rotation that occurs in the sacrum, because they compared it to this tiny bit of motion that the earth goes through. It's called nutation. I don't know. So if anybody, I put this up because I think everyone should read, the students of anyone who's a student of spine. Ron DeWald always used to say he was a student of spine. If there's a true student of spine, you should read this article. It's a great article on MRI findings and sacroiliitis. And I know that's not what we're talking about, but I think if you're interested in spine, it's a great article. It's from Germany, and it just has everything next to each other. So you have the cartoon, the anatomical specimen where the cut is, the histology where you can see the sacral portion of the SI joint has a lot of cartilage, the iliac portion does not. And then you see the histology on the right is the sacral portion. The cartilaginous area is mature, looks like a normal joint. And on the left side, it's fibrous and immature, the iliac side. So the iliac side is a lot different than the sacral side. And this most important part here on the bottom is you can see the difference between the fibrous portion of the joint, where it's all ligaments, and the cartilaginous portion of the joint, which is more anterior, and they're very different, and they're full of fat. The place where the fibrous portion of the joint is full of fat, and it's a lot wider, as you can see. So I'll go quickly over this, but this is just a depiction of the MRI is extremely sensitive for sacroiliitis, and they use this for ankylosing spondylitis now more so than like blood tests. And this is early disease where the uptake, you can see the uptake in the joint, and also on the right is after gadolinium enhancement, the enthesitis of the inflammation of the tendons and insert there. And then as the disease process worsens, you get erosion, first on the iliac side, across the joints. The whole joint can have uptake later on in the disease, and then late in disease there's less uptake because I assume there's less inflammation and it's starting to fuse, and destruction of the cartilage, and then finally the joint's gone. So now I think we should probably get MRIs on these people if we think, because if an MRI is normal, well, I have a personal theory, and everyone may think I'm stupid, but I don't operate on normal MRIs. Like, I'm very nervous.
Looking at that, I'm going to go back to that.
Which one, the pelvis?
The pelvis, actually. I want to make one point to people. Because you're going to start, talking about SI, this is SI joint fusion, you're going to start putting stuff across the SI joint to try to get it to fuse, however you do it. And I'd like to point out one thing that I learned the hard way, is you guys can see on this kind of outlet view of the pelvis here, you can see S1 and the S1 foramina, and then you can see the S2 foramina, okay? The fixing into S2, you might be able to fuse down into S2, but fixing into S2 does not work. And the reason is simply in front of you, that the weight-bearing axis from the leg up through the column of the pelvis up to here actually is a pretty straight line. Go grab a pelvic model and see the thickness of the bone just anterior to the SI joint. That's where all of your weight gets transferred through. This is real bone because the axis of weight bearing is just like that. It's a line from the femoral head right up into the sacroiliac on the same side. There's very little weight bearing depending on your anatomy. Now, there's a lot of changes and variation in your sacral anatomy. But fixing it here with screws and trying to get good screws at S2 and wanting to get a good bite, in my experience, it does not have a good bite, and you don't get good fixation. So I'd be aiming, if you're going to truly try to compress the SI joint with something like screws, which is what we do in trauma, and is what I did when I tried to fuse these things, your bite and your fixation, if you believe the amount of fixation you put into it helps your fusion, aim at S1, don't aim at S2. That's my point. It's simple anatomy, but aim at S1. Even though the joint is actually a little below that.
Okay, that's interesting. So just the outlet, inlet views show you different portions of the anatomy, and I won't go into this, but you can see the angle of is 90 degrees for the inlet view, and the outlet view shows different portions of the sacrum. So this is another case, interesting case of true sacroiliitis. I performed an L405 fusion for severe stenosis spondylolisthesis. Patient never got better, so I had no idea what was wrong. So I ordered a CAT scan to rule out non-union, an MRI scan to rule out recurrent disc herniation, and a bone scan to rule out some other pelvic fracture. And she had rip-roaring sacroiliitis, both sides. And the radiologist said rule out hyperparathyroidism. Sure enough, that's what she had. She had a benign tumor, and that was giving her severe sacroiliac joint pain. And she also had a spine problem, so I fixed the spine problem, but she had two problems that gave her low back pain. So that should always be in your differential. This is another case. I revised this case, but I didn't do the first one. But basically, it was a PSO that had a non-union, and I revised it because it failed and the implants broke. And look at her sacroiliac joint. I just saw her last week in the office. So she's basically, that's where she's probably moving. And she has a lot of low back pain. And you can see how it's sclerotic, it's widened, definitely diseased. So this is another question I posed to everybody. Is okay, so sacroiliac joint, it's innervated, it's a cause of pain, it moves. Why are spine surgeons putting screws across it for deformities? I mean, isn't that going to be a source of pain? Yeah, I'm asking everybody. I don't know the answer to the question. But this is routine now. So,
Well, there's two techniques. I mean, there's the extra articular approach where you're going through the iliac crest and you have a cross.
that's not what I'm talking about.
The S2 halar screw.
That's what I'm talking about. Right.
Where you are going across.
It's easier. It's easier to line up the rod and yeah.
And it's, I would say it's done more often right now. You're right, and
it's right across the joint.
Right.
So for me, it's like the cognitive dissonance. Like, what's going on here? Is the joint a source of the pain, or is it not a source of pain? Actually, Bobby's in the room. What do you think, Bobby, about a screw going across the joint?
I think the SI joint is an odd actor, and the number of people with X-rays that have SI joint disease on them that you could see if you're seeing a lot of people is huge. And many of those patients, I realize we don't walk on our X-rays, but if you see somebody with terrible degenerative joint disease in their knee, likelihood on your exam, they're going to have a little bit of a contracture, or they're going to have a little bit of swelling, and they're going to say, it really doesn't bother me very much, probably because their level of activity is such that it's not a big deal. But radiographically, we see an awful lot of disease in people of SI joints in people who don't have SI joint symptoms. So, and in my experience, I've put an awful lot of stuff across SI joints for trauma. Those people don't come back with SI joint type symptoms.
They don't.
They do not. They've had these big pelvic ring disruptions, and you got screws going across it, and maybe it was a sacral fracture or whatever. Yeah, I think we kind of just disregard it. Your point is absolutely correct. How do we disregard putting screws across it? If I put a screw across a joint of your wrist, or it's going to, if it doesn't fuse, you would think that it would.
We don't put screws. Yeah.
And you would think it would cause symptoms.
We don't put screws across joints.
No, without doing something to the joint.
Yeah, that's sort of like orthopedics. We don't do that.
Yeah, but I think it's a different situation when you're doing a pelvic ring fracture and you're going across the SI joint, and if you're doing a multi-level lumbar fusion and all your lever arm is now at the SI joint. I think that could be why it hurts. In the latter,
you're talking about like a junctional disease in the spine,
right? And the reason we do it, of course, is because to avoid the more severe consequence, which is a sacral fracture.
Yeah, we need fixation.
So we need fixation. So we do it in that extreme situation. Most of those patients don't have pain. If you think about it, if you're fixing that joint, then maybe you're stopping the motion, especially if you're getting good fixation.
I hear you.
So I think you're not. It's when you get the screws start to get loose in that.
Well, do you guys see that?
Junction.
You follow up a lumbar fusion for 5 years. Let's say, and you put a screw in like this. Do you see lucency around the screw?
Occasionally.
Do you?
And I've had some patients where I thought they definitely had pain coming from the loosening there.
Have you ever gone back and done a fusion there on those patients?
No, but I have discussed this with Kabesh, who does a lot of these. I said, what do you do? Would you take the screw out? Now that if your fusion is solid, would you just go in and take out the screw? And that's what he would do. But then I said, well, then don't you increase the chance of a sacral insufficiency fracture now that you've taken that out? He said he hasn't seen that. So I have not. The patients have done okay and well enough that I haven't had to do anything. But that's what I would consider doing, is just taking out that one screw after the construct is solidified and it's accomplished its goal.
Okay. That's a good point. So just non-operative treatments, I don't know, I've never prescribed a sacroiliac belt, but it's an option. So the gold standard for that, the people who do a lot of SI joint fusions, they say is an injection. So, and 75% of relief twice to prove that that's the area, the radiographic injection. So it can be done under fluoro, or it can be done under ultrasound. So I thought this would be interesting. This is Paul Durian's friend. That's why I included him. He's my friend too, actually.
In this video, Dr. Walter will explain injection of the sacroiliac joint under ultrasound.
It's on the floor.
Okay. Well, for the sacroiliac joint injection under ultrasound guidance, we'll have to place the patient in the prone position with a bolster under the pelvis. That actually eliminate some of the lumbar lordosis and expose the sacrum, we found the iliac crest up to the dimples of Venus, which is the 14 point. And that was
It sounds like penis, but he said Venus.
we know at the upper level of the
Dimple of
sacroiliac
Venus, yeah.
is fibrosis.
Yes,
There's a lot of full with ligaments, but actually that's the area where it's more painful. So for our localization,
Yeah, he made a point. It's better to put he thinks the injection in the fibrous area,
and when I looked at
the fibrous area of the joint, because he thinks that's the most painful
I can see
area.
the sacrum with the spinal processes in the center.
Show me where the sacrum is.
This is the sacrum with the spinal processes there. If I move laterally, you're going to see the ilium coming about. That's the ilium. From this, it is important to identify because if you put the needle too more medial, you're going to end up doing a transforaminal S1. S1 transforaminal epidural injection. So once we found the ilium there, you can see the hypoechoic region. It's a big piece of bone. You can't miss it.
The black thing.
The black thing is completely opaque to the ultrasound wave. You can see the divot underneath. That's the sacroiliac.
That triangle, that's where he puts
All
it.
this stuff is fibrosis.
Okay, so this big black thing is the ilium, goes to your superior spine,
Mm-hmm.
and this is soft tissue where the joint is.
Where the sacroiliac joint is.
Sacroiliac joint.
So pretty much we introduce a needle medial to lateral to it. Under 45 degrees, you could probably can see following the bone until it just hits the bone.
I think that kind of, the rest
And-
that's pretty much it. I'll just keep going on, because that's basically it. So that's where Walter does it, his injections, and it stops, because you can't go deep, you can't go into the pelvis. The joint stops you, and that's where he injects it.
That's actually quite interesting. Do you have anything on the slides when doing the injection? You have to talk about that again.
That's it for injections.
Okay. I will tell you that I think that's a broad definition of what the SI joint is for me. The joint to me is the diarthrodial joint. And I will tell you, I disagree with Walter. I didn't know that he did it that way. I think you can easily get into the fibrous portion of the joint, but you're not. What are you injecting? I've been there. I've looked at that anatomy. It's a bunch of fibrous tissue and scar. How do you know? And it's big. It's several inches in length alone. So I don't agree with that. The only way I can get into the SI joint for an injection.
So you're saying it goes into if you look at the SI joint, you're saying it goes into the darker one, and
I'm
that's
saying
not,
you can easily get into the darker one,
yeah.
but
But you want it in the
to me,
cartilages.
it's funny because I'm learning something here. I've never considered the ligamentous portion of the posterior SI ligaments as part of a joint. And the way we're talking here is this is the interosseous ligament region. That's true, but it's not part of the joint. It's not anatomically the joint. It's the ligaments around the joint. The medial collateral ligament of the knee is not part of the intra-articular portion of the joint. If you could just inject the medial collateral ligament, you would not be getting your injection into the joint and not not diagnose intra-articular pathology. So I disagree. I will tell you that and I'm bringing a very old, historic kind of way of doing this. I argued with the people who were doing them under fluoro. I felt that they couldn't prove to me that they were in the joint, and I sent all of mine to be done under CT. And I sent all of mine with the instructions that there is no lidocaine given except in the skin until the needle's in the joint. I was looking for a U.S. military surgical drone strike. I wanted to make sure the needle was in the joint, and you can only put a cc or so in there.
They would do an arthrogram. They would actually put dye in.
It is an arthrogram, but I just want to see the CT cut with that needle in the joint inferiorly. And then I knew they were there. It would extravasate because the capsule is kind of insufficient, and it takes multiple attempts to get it in there. But the idea that he could get it in there doing what he's doing,
He's not
trying. He's
doing
right.
right.
And that may be therapeutic, but I don't think, for me, this was a pre-surgical diagnostic test, and I wanted it to be accurate and reproducible every time. So I would not do that if I were, and by the way, I'm not doing SI joint fusions anymore.
That's okay, that's okay.
That's a whole new thing.
I know, but you have a lot of experience, that's why you're here.
It's
important.
a similar situation of doing a intra-articular facet block versus the dorsal primary ramus, where you really don't know what the heck you're injecting, versus a true intra-articular injection where you know you're in the facet joint.
That's the exact same philosophy.
That's a very good point. So other treatment options are radio frequency ablation. So to denervate basically the SI joint in some way, which comes from the sacroforamina, and there's a whole art to, or science, I don't know, of where to put the needles exactly. And there are many articles for this. And interestingly, for this model, they did an SI joint fusion. See where the screws are on the right? It's kind of funny. So, so pelvic fractures are very common, and we already talked about it, but people have been putting screws across the SI joint for years and years and years and years. And the question is, what does it do? Is it a source of pain? Can people live with it? So Bobby's saying maybe both, right? You say some people are fine, some people it bothers them.
I think it's interesting because some people, the screws back out. Some people you use screws. Notice on this film, these screws are fully threaded, meaning they're just trying to hold it there. They're not even trying to lag it together. Most of the time you have widening like you had on the previous slide, and so you try to squeeze it together. But I've had people, once they solidify, and this anterior ring fracture that you see down here on the left pubic ring line and inferior ring line, once that heals and the ring is solid, they tend not to have a lot of pain. But they also maintain what, I don't see their SI joints dissolving over 5 years either. That is radiographically fusing. Their SI joint's still there. I've seen a windshield wiper and halo around the screws indicating motion. I've seen the screws back out, and I've seen them sit just like this and look great.
Screws break? Have you ever seen screws break?
More back out than break, but I'm sure I've seen a broken screw. I've never gone into a sacrum to take out a broken screw, though. I wouldn't want to do that.
Do people come back to you and say, my SI joint hurts, can you take the screw out? Sort of? Have you ever done that?
The honest answer is that if you have a disrupted pelvic ring and you kind of get it back together and well aligned, most of those people, they don't have to be absolutely anatomic. Most of those people come back and say, we're doing okay. I never asked. I never paid attention. I was just happy that my work had been okay. You know, here's what you went. You had the problem was a displaced pelvic ring. You kind of got it back where you wanted it to be, and the person comes back and says, I'm okay. It's not quite the same, but I'm okay. And if you look at the studies on quality of life after pelvic ring disruption, there's a wide variety in the actual results of that. But, you know, unless you're truly trying to decide whether this is now a continuing SI joint problem from a pelvic ring fracture and fixation, we weren't in trauma. We weren't smart enough to ask. I certainly didn't examine it for it. I didn't do a single Faber test on anyone like that. I just didn't do it. I should have, but I didn't.
Okay, so that's where I'm going a couple weeks, taking my kids to Disneyland. So Smith-Peterson technique. This is the Yeah, definitely. So the Smith-Peterson technique was in 1921. So Paul was in residency, and it was very common. So I looked up SI joint fusions. There's I think 19 on the market now, and these are like, I don't know, 10 of them. And
they don't even have the most common one now. They started the whole thing.
I'm gonna show the most common one, but so they're very variable. Sometimes they're just basically hollow implants that bone's in the middle of that you expect to fuse through those holes. Some of them are allograft. The bottom left is sort of like the Smith-Peterson technique, and some of them are hydroxyapatite that fused. Now, CMS has increased the work relative value units from 9 to 12 this year. So now this fusion is about the same relative value units as a disc, lumbar discectomy. So our case is a Rialto. This is a Rialto. It's the Medtronic one. And this is the technique that's on their website. And they promote doing it with the Medtronic stereotactic guidance, and not 90 degrees to the joint, but rather like an oblique. And their theory is you avoid the musculature of the gluteus musculature, and they're less pain. I mean, my personal opinion is that I mean, it's not as good fixation, and people don't have muscular pain from their gluteus percutaneous incisions. What do you think of that, Bobby?
I agree.
Yeah. So, but this is what they espouse, the company, and this is on the website. Is a perfectly placed SI joint implant from the oblique view.
Was that a fused SI joint right there?
Yes, that's their fusion of SI joint. I mean, whether this is fused or not, I don't know.
I'll give you a maybe.
Okay, so this is the one Paul's referring to, which started it all, the iFuse implant.
The rigid titanium construction and triangular implant geometry provide immediate stabilization.
So basically, you grow into this thing, right? The bone fuses to the metal.
More than
As you can see, this is
And this is just the technique. It's basically, it's nothing special. It's what you expect. It's just like it's like a pelvic fixation, and 3 of them across the SI joint. So it's just like putting the percutaneous screws. You drill, tap, and then put the implant in, and the implant's triangular.
If I could
triangular implant.
just bring my fixation tab on.
Yeah.
The video just said immediate fixation. I cannot imagine that anybody who does any bony work in the pelvis thinks that there's immediate fixation with this. You're putting a metal dowel across the joint. If you think that really fixes it, that's fine, but it doesn't.
They put 3.
The third.
Yeah.
So you fuse to that. But then like.
I'd like to see some pictures of those fusions.
Well, this is a classic example of a Wall Street creating a problem.
Bingo.
This is what Bernie is all about, right here, baby. This is the Bernie procedure. All right? You do this operation that, and you're not feeling the burn.
Let's not talk about brain.
So this is the classic thing where now they were talking about the number of people with side joint pain being.
Well, they estimate 30%.
Yeah.
That's what they say.
Bullshit. I've been in 32 years of practice. I can't tell you how many
maybe
people
1%.
I truly have had SI joint pain documented with positive, SI
It's very, very rare. It's very, very rare.
But according to their data, they created this whole market to sell this product.
And that is the key phrase, they created a market.
Yep.
Well, I think the industry influenced CMS to increase the relative value units as well.
Right, because
There's a
you were
big
getting
push.
nothing, so doctors
Yes.
do the procedure.
There's a big push.
Exactly.
Let me show
Well,
you.
what happens with any new procedure is the actual RVUs are relatively high at the beginning, and then they drop lower as it becomes either accepted or gets discarded.
This one went up. This one went up 30%.
SI joint was one of the first things, so that was always the lowest RVU. Was
Good lobbying.
Newer procedures would have higher codes, and now they just recently increased it, as he's saying, to make it more competitive, so surgeons will start to do the procedure.
Oh, they will. They could do, 5 of these a day?
Yeah, it's a quick procedure. So let me just go over a couple more things. This is the Globus product, which is hydroxyapatite coated with a hole. So basically you fuse this, but my thought is this thing will eventually break if there's motion. I don't know, maybe not. Bobby says he didn't see many broken screws.
I don't think they break much because I don't think there's that much motion across the joint.
But this makes that one.
It doesn't have to get very loose
That
for
one
it not
makes a
to
little
break.
sense because you're supposed to have bone going through the implant right at the articulation. That's why it has that hole there. So you have a place versus just a solid screw. You're providing a pathway of fusion across the joint through the implant. That's why those
I mean, it's a small hole though.
holes are. Yeah.
So this is just the technique is similar to just putting the screws across it with pelvic fractures.
But this is a
Which is
great
nothing new.
procedure for robotic technology because the anatomy is, you have to really be careful with the framing and stuff, but with robotic technology, you could plan it and just drill your holes right where you want and put the screw in. And
Yeah. I want to show you guys one more I found. Have you heard of this? Yeah, my daughter, She would not get off the
Approximately
phone.
20% of chronic low back pain originates in the sacroiliac joint. But because SI joint dysfunction can mimic other etiologies, with pain presenting in the low back, buttocks, down the leg, and sometimes in the groin,
This is an
it is
interesting
often
technology.
overlooked. The Symmetry Sacroiliac Joint Fusion System is the minimally invasive surgical treatment founded on proven orthopedic principles of joint decortication, bone grafting, and fixation. The key is the Symmetry Decorticator, which removes cartilage and decorticates the articulating joint surfaces. The cavity
Sorry,
created
guys.
allows placement of bone graft. The result is a true SI joint arthrodesis and the best possibility of relief for your patients.
That's basically it. It's kind of interesting, isn't it?
To begin, a guide pin
And
is
so
used.
the rest, yeah.
Except not with that kind of technology.
So I think we reviewed everything. So back to our case. So here are the screws. The MRI I felt was benign. Some mild bulging discs would not explain her symptoms of a lumbar spine. So here's the CAT scan. And she said she never got a post-op CAT scan. One of the screws, I don't think ever made it across the SI joint.
It looks that way on the X-ray too.
Yeah. Now this one looks like it's going across the joint in the fibrous portion. See that?
Yeah.
So I don't think either of these implants are across the joint.
I agree.
See that? See, this one stops just short of the joint. Unless it was across the joint and migrated, but I don't think so.
The there looks like it's across, the other looks like it's across there.
This one?
The
most
posterior
posterior
one.
Yeah, this one is across what I would call the fibrous portion of the joint.
Right.
See that?
Fibrous portion. Right.
So what would you guys
I'll make the
do?
assumption that your pelvis is perfectly positioned in your CT scanner. Notice the changes in the iliac joint are slight, but I mean, I think you're right. I think that the posterior one is a little bit more inferior and therefore probably has a better chance of actually going across the diaphragm.
It's close.
It's close.
So here's the coronal sections. I don't think it's across the cartilaginous portion.
I don't think it's huge.
Yeah. No, I don't think so. I would sincerely doubt it's fused.
So what's your pain like?
Just classic SI joint pain. Classic. All this exactly SI joint.
Have you been injection? Yeah.
No. So this is the end of all my slides. So what do we do? I have my own plan, what I think, but what does everyone think? How about Bobby? Can I start with you? What would you do?
I would put her back in the CT scanner, and I would do a documented intra-articular inferior needle into that joint and give her as much as she could tolerate. I usually put it in. Carlton used to do it for me. I would do some of them when we were trying to make them, get the technique right here in this hospital, and put a little dye in it. You're going to see some extravasation. Do not go and when you put these needles in, these patients jump. And so don't put a lot of lidocaine everywhere else. You're gonna change what your test is showing. Get the needle in the joint, and I think the 75% relief is crazy. I think if you truly have SI joint, diathrodial joint pain, Novocaine in the joint should give you close to 100% relief. They should get off the table and within 5 minutes go, that's the best day I've had in the last 5 years. And if that patient had that response to that test, I would do an SI joint fusion. By whatever technique you guys want to do it, I would take out these things and do it. If they didn't have that response, then I would not do anything. And I'll tell you the reason why, getting away from this case, is I probably did 30 or 40 of these, and I never wrote them up. But what I found is, if I got some of them, I got great fusions. It was not the 85, 90% that I'm reading in the articles that you sent for this conference. I did not see anything like that. My fusion rate was probably 70%, 65%.
But some of the patients who got fusions still had pain, which means, in my view,
Fused people
still had pain, which means I didn't accurately enough pick the right patient. And some of the patients without fusions got better. So what I found is that it became to me a crapshoot, that I truly didn't know, no matter how well or how lucky I was to get it right, or how well I did it, and whether I got a fusion or not, I couldn't be predictable for the patient. And so I stopped. But in this patient, if they're truly having the symptoms that look very much like SI, I would put in the CT scanner, get a needle documented SI joint. If they got miraculous kind of inject the knee kind of response that you see with people when you inject joints, then I would do it.
What if these things are causing pain? What if these implants are the cause of the pain? So my thought is, what about let's just take them out?
Well, I think that's a reasonable step because it's so small, and I think that's reasonable. I hadn't expressed that, but I think that's reasonable to see if that helps them.
Take it out and then see what happens, and then if she still has pain, then do the needle.
Sure.
And then
I'm fine with
fuse her.
that.
Yeah.
I'm fine with that.
So then we kind of
approach.
Yeah, because I think these things are causing the pain now. I think the ones
Except they were put in for presumably the same pain, so that pathology that was causing it was still there. So you don't know, but I think taking them out is reasonable.
If someone tried to fuse a knee and had some screws and they did not achieve a successful fusion and the screws got loose and started to hurt, would you ever just take the screws out and say, now try walking on your knee again, see if it doesn't hurt anymore?
If it was a normal knee, I would. So
I don't think I've been comparing this as like all diarthrodial joints are the same. This one has a different personality than the knee. There's a lot more motion there. But I think you could. I think you could take the screws out, and I think you could do that. I think you could tell them, I think you're still going to hurt it, but I think part of your problem is these screws working around your joint.
I mean, if this person's in the operating room and you're taking those screws out, why not just re-instrument better?
Because
I probably would. If their knee was so damaged to need a knee fusion, I would probably redo the fusion.
Let's stick with the SI joint, because I don't think knee is the appropriate analogy.
I agree.
But if you're taking these screws out, why not re-instrument the SI joint?
Because I'm not so sure that was the cause of her pain in the first place. Because I think this procedure can be overdone sometimes.
Oh, I think you're going to see more and more of it.
Yeah, for sure.
Right.
And then what do you do with the person that has a non-union?
I have revised a couple, and the revisions were successful, I think, except for one. I'm kind of just pulling this out of
The Smith-Peterson technique?
Yeah, well, I was doing originally a block window out and going directly in. And then this hospital was incredibly helpful for me. I did about a dozen or more of these in the CAT scanner. I put an operating room in the CAT scanner prone, and what I would do, this isn't the best cut to show it, but what I would do is make an incision over the posterior iliac crest and obtain a bunch of posterior iliac.
Hold on, so is this helpful?
Yes, if we go, so I operate in kind of two areas. Here, I would go in posteriorly, pop the cap off the posterior iliac crest and go down into that wide posterior iliac. I'm talking about maybe the upper row here.
Here?
Yeah, or come down, the middle one. Right.
So you
go on
do
the side that I would go right there and go in and take that posterior iliac crest out and then bone graft. And then I would go further distal in the pelvis. Go ahead, go to your next slide.
Here.
No, the actual next slide.
Here, why don't you do it?
I don't know how to do it. I'm going to go to the, hold on. Put me back on your CAT scans, because you had two sets of CAT scans.
Yeah.
One was more proximal. This is the proximal one. Where's this? So as you can see,
point with the pointer.
Once you get distal,
Just don't hit it.
once you get distal, then the SI joint is very obvious and superficial. The diarthrodial portion comes all the way back as you get very distal.
So you find
more
it under the
proximal in the
cascade.
pelvis, I would go and take bone graft, and then I would come down through a little incision at this area and come in and dissect down the SI joint, and I would take a burr, and I would take a burr and just go in and would burr this trough right here. I would burr this trough out, and then I would pack that with bone, and then I would put two SI joint screws in the way I would fix a pelvic fracture. That was my operation. And I got to tell you, I give all the credit to radiology and the hospital for letting me do that. I did about a dozen of them down there. And some of them still didn't fuse. But it's a bigger operation than just putting some guide wires in and firing these hydroxyapatite or titanium
things across, but that's what I did. We're talking 15 years ago.
Do you think, now that this is getting more popular,
Yeah.
and we got a lot of spine involvement with doing this, do you think that trauma is going to jump on and start doing SI fusions and doing, the same procedure, just from the trauma side of things?
I think whenever you put another nail in the toolbox, somebody's going to hammer it into the wall. And I think if you're going to do, for instance, it's an analogy to the foot. Dislocated Liz Frank joints, primary fusion is one of the things that they do, as opposed to just fixing it there. Some people do a primary fusion. You could end up with that if you think that SI pain is a problem after pelvic injuries, but somebody's going to have to prove that to me first. We're extending the indications before we have the science and knowledge to truly know who's supposed to get this and what's the best way to do it.
They've been studies like Paul Lee, who's looked at if you have 3 out of the 5 positive signs, there's a sensitivity to this. And I will tell you that there's a group out there who believe it's all baloney, won't do it, like myself. And then there's probably a group of docs who are drinking the Kool-Aid that are going to be doing a bunch of these, look at their results and realize maybe this doesn't really make sense, like newer technologies come out, and then the people who are honest and who look at their results and who are really into help patients will say, I'm abandoning that procedure, just like it was the IDET. Remember the old IDET procedure where they were burning the nucleus.
Spine has 20 procedures that have come and gone.
Right, they come and go. Yeah. And I think, so I'm not convinced that there's going to be just a continuous logarithmic increase in this procedure.
Oh, it will flatten.
It's going to do this, and it's going to start to do this.
Every procedure gets popular.
Well, everyone wants to say they're doing the newest and latest technology, and so I think that's what's probably going to happen with this. And on this patient, I'd inject her L3-4 facet on the right, on the left side, because she has 3-4 disc herniation, and she may have referred pain from her.
Facet or epidural? Just the facet.
I'll do a facet. I would consider also an epidural at that level to see if see if that eliminates the pain. She may have referred pain into that area. I would look at other things, but going in and taking the screws out, I think it's reasonable. It'll make it easier for you to do the intra-articular injection. But
one of them is pretty prominent, so that may be a source of one of them.
Yeah, so I think that's reasonable, but I would also look at other alternatives. Despite your clinical exam, I would look at some other. She does have a disc herniation of 3-4, unusual in a young person. And could that be a source of referred pain?
I'm sure it's her SI joint on exam. It's clear.
One other point, therapists. You guys therapists, by chance? I don't know either, sorry. But there is what I used to refer to as Gestapo therapists. I don't mean that negatively. They are so full bore convinced about SI joint motion and relocating patients when they evaluate them, that patients get the idea that it's their SI joint sometimes before they get
it's the dislocated SI joint that's relocated to the therapist.
And I had one patient who the patient requested, and back when we could just let anybody in the operating room as long as they were in scrubs, that the patient requested that their therapist come preoperatively on the table and locate their SI joint before I fused it. So there is that. You're going to run into. It's become a cause celeb amongst a small but very vehement group of therapists. So be ready for that. I'm not saying that they're wrong. I'm saying they may be right.
No, it's a big group, Bobby. It's a big group that does that. Yes.
Because they will.
Don't you agree? Relocating SI joint dislocations, etc. Chiropractors.
I haven't seen that much, but I'm not sure.
Is that a procedure we can do a bill for?
I'm sorry?
Is that a procedure
It's big.
bill for?
Yes. And they're the primary caregivers for orthopedics, basically, in the county.
The fusion will run by your insurance, but the reduction is cash.
Only you.
All right, so that's any other comments about SI joint fusions or this case?
That's not how it happens.
Yeah, I will. One before we go, I want to ask Bobby a question. Out of all the technologies that I showed you, what did you feel was the most compelling or most reasonable or most interesting of the SI joint fusions?
I'm not at all interested in sticking a micropore dowel, triangular dowel across the SI joint and saying it's going to fuse. I think that's hocus pocus. I had a hard time filling these things with bone graft and getting post-op CAT scans on every one of them and looking at the destruction that I'd done in the joint and putting bone graft across it and had 2 lag screws across it, and a bunch of them didn't fuse. They don't fuse for a reason, and to think that we can percutaneously fire these things in and get 85 to 95% fusion, to me, I don't buy it. So I'm not wowed by any of the technology that you've shown me. I'm just not. It doesn't make any sense to me that we just stick something in there that gets bony ingrowth over here and bony ingrowth over here, and the joint problem in the middle just goes away. It doesn't make any sense to me. I mean, I think you have to take out the joint and destroy the joint and really get numbers.
But if there's no motion going across that joint, then what's the matter with it?
And you have to prove that to me. I mean, it's something that takes this much stress.
Well, I think about like a standalone A-lift, if the patient has bad facet joint pain in the back, once everything's
Fused, it should stop.
fused, it doesn't matter what the facets look like anymore because you're not moving on each other.
I just think that if you look at CAT scans and MRIs of these things, it's really hard sometimes to tell whether they're fused. And I think just however they're getting the rates of fusion, and I should go back. I read the 4 articles that you sent, but I want to go back and read the articles on which those review articles were based.
They're all industry sponsored, so it's not clear if it's influenced.
So nothing I've seen with the more modern look at it tells me that, oh, I'm going to now relook at this and start doing this again if I were actually seeing those patients again.
And then the other thing is from spine, non-humans can be serpiginous and very thin and may not be obvious on the CAT scan. Although CAT scans have gotten a lot better.
I guess one other question I have really is, doesn't matter if it fuses or not. When you have those 3 dowel rods across there, internal sacking is 3 separate points of fixation, that gets rid of that mutation.
Fibrous fusion, that's what some people
I agree
call
with
it.
you in a static sense, but when you do that, if it's not fused and you do that over years of having this micromotion take place at the joint and they're not fused, I don't see that they're doing anything yet. I think the joint, the motion will return. The amount of stress we place across those things is huge, even though the amount of mobility is small.
Well, the concept is bony ingrowth into those dowels, so that if you have 6 points of bony ingrowth, 3 from each side of the joint, then it's not going to move. You're not going to have motion of the joints. That's the concept of those dowels.
And I understand that. It's a question to me. I don't really understand how well they work.
Yeah. Whether it's true bony ingrowth.
I mean, for how long it took me to do this and how much effort it took me to try to do it open, I'd love to do it percutaneously, but boy, to think that you could just put 3 little screws across or 3 little somethings across it and fuse an SI joint in, 45 minutes? That's really something. I'm going to be from Missouri. You're going to have to show me that it fuses and show me that the patients are better. Because just because their studies said that those people were happy that they'd had a surgery, and they would do the surgery again, it does not mean that you have actually attained anatomically what you want to attain.
It could be placebo.
Sure.
Yeah.
Interesting subject. I'm sorry you brought it out of my memory. I forgot.
I'm glad you came. Thank you, Bobby. Thanks for coming. I really appreciate it.
Thanks for having me. Thanks for inviting me. I think it's great. Because you were around when I was doing it.
Yeah, we did a couple together.
Well, you don't do it. You're not on bandwagon.